We've got a great lineup here of high quality experts in the medical management field and in the pharmacy benefit management field. We'll be using a Quizzify-style methodology, question and answer. And without further ado, I'm going to introduce our Quizmeister in Chief. And that's Al Lewis. And most of you know Al. And as you know, he's one of the foremost authorities in wellness and population health. And what relates to this webinar is the book on the right there that he co-authored with Tom Emmerich. And Tom managed benefits at Walmart for more than 12 years. As most of you know, Walmart is very much on the forefront of big innovations in healthcare for their employees. And in this book that they authored in 2013, they actually talk about the how to properly manage pharmacy benefits and how to avoid some of the pitfalls and how to get the right drug pricing for your employees. In addition to that, there's another section in the book that deals with proper medical management. And we have two people today that Al will introduce that are experts in that field. So without further ado, I'll turn it over to Al.
Thank you very much, Mark. And the first thing we're going to do is we're going to go through why we're all here today, why the three of us are here today. Mark, you can go next slide. We're here because it's not just that we have three of us here together, which we do. We've got us, we've got Ault Medical Management, and we've got Drexi. It's not just some random group. We actually have this thing that we call the Valid Vendor of the Month, where if we pick a vendor as Vendor of the Month, we actually guarantee, we, Quizify, put some of our fees at risk for joint accounts to guarantee their results. There's nothing like this in the industry. And there will be a live link so you can actually look at the fine print. And here's a newsflash. There isn't much fine print. There's hardly any fine print. We have never presented together with these folks, so this could be a little bit rocky, but on the other hand, you have to remember that the first time Crosby, Stills, Nash & Young ever presented together was at Woodstock. Next slide. So I will start by introducing Ault International Medical Management. I like to say I knew Nurse Deb before she was Nurse Deb. I knew Nurse Deb when she was starting in her basement, and she has grown Ault International Medical Management to 300 customers since 2003. As you will see, they average almost 50% lower than the index, and we actually, Quizify, will guarantee some chunk of that 50% to our joint accounts. Now, I found Deb after an absurd case management experience of my own that I'll tell you about along the way. Next. Okay, so get ready with your polling question here. We're going to start with what are the two largest categories of hospital spending? Are they diabetes and heart attacks, birth events and musculoskeletal, transplants and heart attacks, or diabetes and transplants? And while you're putting up your answers, I'll tell you this experience. Okay, so I'm sitting at home minding my own business, and my health plan calls, and I'm thinking, oh my goodness, I must owe these people money, or I've done something wrong or something like that. So I pick it up, and they say they're calling from the case management department about my condition. And I say, my condition? They said, yes. And I said, well, what condition do I have? And they said, oh, we can't tell you. I said, excuse me? They said, well, you have to give us permission to open your file. I said, fine. I am curious to know what condition I have. So they opened the file, and they said, well, you have bladder cancer. And I said, yes. 3.5 months ago, I had a quote-unquote non-invasive bladder surgery to remove a stage 0 tumor. I haven't frankly thought about it twice since then. And I just have two questions for you, which is, why are you calling me about a day surgery that took place, number one, a day surgery for a condition that resolved that took place 3.5 months ago? This is not how you do case management. And that's what Deb's going to tell us about. Okay, survey results are in. The survey says birth events and musculoskeletal wins by the survey. And in fact, it actually is the correct answer. Wow. Okay, now on the other hand, 2/3 of people did say other things. So let's go to the actual data. And here it is. This is cut and pasted from the government data where all the hospitals report on the costs and the total number, total expense of various medical procedures. And these are the top 25. You see a lot of birth events. You see a lot of musculoskeletal. You don't see diabetes. You don't see transplant. You don't see heart attacks. So, Deb, I'm going to turn it over to you. Tell us how you manage these folks and how you don't end up in a situation like mine, and how you specifically look at all these diagnoses and not just diabetes.
Absolutely, Al. Well, thanks for having me. The key to this being successful is a patient-centric, comprehensive care management approach. As a matter of fact, it's so much of a key that we trademarked and have a patent in process for P3CM, patient-centric comprehensive care management. It includes the pre-certification process. So I'd be willing to bet, Al, number one, that before you had that day surgery, somebody at the doctor's office or the surgery facility called into your insurance to check and make sure you were effective and eligible, make sure you're covered under the plan, make sure it was a covered benefit, and to ask, does it require pre-certification? That should have been red flag number one for medical management to get involved that day before the surgery ever happened, to make sure, were you getting the right care? Was it happening at the right time? Were you going to the highest quality, most cost-effective venue to get that care? Did you have all of the patient education and pre-op education that you needed to be successfully prepared for that procedure and service? Did you have good transportation to get there? Do you have somebody who's going to be your advocate? There's a whole list of stuff that should have been happening 4 months earlier than what it happened for you. So a little bit of a different approach than what you experienced, wouldn't you say?
Just slightly. Like, one of the things you would have told me about this is that I should go to a hospital that has a dedicated cystoscopy operating room, as opposed to just an operating room that they use for a ton of things.
Yep, or an ambulatory surgery center that has that, which would have been even better than a hospital.
Indeed, I would have ended up paying a lower coinsurance. Next slide. And then we have another polling question, because one of the other things that Ault works on is, in fact, imaging. So the question is, how does the radiation in a CAT scan compare to the radiation in an X-ray? Is it 500 times as much, 5 times as much, about the same, or the X-ray has more because the CAT scan is a different technology altogether? Now, while you are voting on that, Deb, why don't you tell us the type of things that you do to avoid unnecessary imaging?
So first and foremost, pre-certification process, right? So we know about 30% of imaging is not medically necessary and appropriate. So identifying those circumstances where the risks outweigh the benefits, and simply going back to doctors and going, okay, this is not really matching up here. Do you want to have a conversation peer-to-peer with our physician and explain what we're missing here? Or do you want us to issue a lack of certification, which is our kinder, gentler way of saying denial? What we're finding is lots of times there are many, many reasons that unnecessary or inappropriate imaging gets ordered. Could be that the physician's just doing a little CYA, medical malpractice aversion, defensive medicine. Could be that the patient walked in and asked for a CT scan and nobody wants to tell a patient, no, that's not really what we ought to be doing. Could be that they're under pressure from their hospital or health system owned practice manager, that they're not generating enough revenue in a particular category. So all kinds of reasons driving inappropriate or unnecessary and risky imaging to happen.
Okay, well, I think that risky might have been a slight giveaway for what the correct answer is. Mark, do you want to put up the polling answer? Oh, the polling answer. More than half of people got the right answer. I actually think, frankly, because we got a lot of Quizzify customers on here who know this. But so close out your own screen, and then you will see that, in fact, a CAT scan does have about 100 to 1,000 times as much radiation as an X-ray. So you can go to the next slide. And just to expand on some of Deb's points, one of the things that, okay, first of all, to Deb's point about the 30 to 50% being unnecessary, if you look at the cut and paste from the newspaper article on the right, you will see that, in fact, the FDA says 30 to 50% of these are unnecessary. Children are the fastest growing category, and yet they're the most vulnerable to the radiation. And there's so many false positives and so many findings people don't expect that they even have a name. They're called incidentalomas. And don't forget about the actual cost of the thing and the stress. Now, one of the things, Deb, that I think that some of the 4 most expensive words in medicine are just to be safe. If a doctor says he's ordering something just to be safe, you can be pretty darn sure it's not needed. So let's go to the next slide.
And be cautious about getting it in a hospital as opposed to an independent imaging facility. That right place can make a huge difference in how much it costs, especially if you've not met your deductible yet for the year.
Absolutely. And yet, despite all this, we do twice as many CAT scans as the average developed country, even though the average developed country has better outcomes than we do. Next. So I know it's not always about me. My first wife was very clear on that. But in fact, this is a place where Quizzify is a nice complement to the type of coaching that, that Deb's organization will give you. We actually have a list of questions to ask the doctor before a medical event or a test or procedure that you can download right into your Apple Wallet so you have them with you when you go to the doctor. I won't get into the details, but you can go to the Quizzify website. We'll have a link and you'll be able to see them for yourself. Next. Okay, one of the things you folks there's Crosby, Stills, Nash and Young. I think they hit a couple wrong notes. Yes, we just gave you the answer to this. It's the percent of cancer patients that are misdiagnosed. And Mark, I think you have to put the poll up anyway in order to keep it consistent with the polling questions in order. So we'll just all put 28% and pretend that that what you see didn't just happen. But you know, they say you should always try a recipe at home before you try it on company, but we've got literally hundreds and hundreds of people on this webinar, so we're doing it for the first time on company. But it is 28%, which is an awful lot. And Deb, tell us how you managed to get things right that the oncologist gets wrong 28% of the time on the next slide.
Yep. How does some nurse who started in her basement get it right, right? Well, it's not all about me either, Al, as much as I would like to think so. But the key to this is, number one, arming patients with the right information, questions, resources, much like you do through Quizzify, as we do as we're verbally coaching them. It's things that are as simple as telling the patient, make sure you get your own copy of the pathology report after the biopsy is completed, right? I can't tell you the number of times that wrong chart is the reason that we got wrong information as they're requesting a treatment. They got the pathology report from patient A and put it into patient B's chart. So they're really simple things that a patient can do. Once that biopsy is completed and they're ready to start treatment, guess what? Require pre-certification for that treatment. When we get all of that clinical information leading up to the pre-certification decision, we send that data out to a world-renowned specialist physician in their particular type of cancer. That's unlike any other medical management strategy in the world. We actually get a second opinion right then and there before they ever initiate the treatment. And that becomes really important because not only do we have a high prevalence of misdiagnosis, but when somebody is misdiagnosed, almost 60% of the time, that misdiagnosis results in harm to the patient. It can even result in death to the patient. 30% of the time, that leads to death of the patient. And oh, by the way, even when they get the diagnosis right, when they write the order for the chemotherapy, there's a significant portion of those, over 20%, that have an error in the prescription for the chemotherapy. So getting that second opinion right then, as soon as that biopsy comes back positive, before we initiate that treatment, and getting a specialist physician involved in that from the outset is really mission critical to these patients.
And one other thing, this is a leading question, but why might an oncologist who does not have somebody looking over his shoulder perhaps order too many rounds of chemotherapy?
Well, not to be overly cynical, Al, but have you seen how much profit chemotherapy generates? It's astronomical. So follow the money, honey. It's what they always told me.
Seems like good advice. And let's move on to the next slide. Okay, Deb, you can wrap up with your 60-second shameless plug for Ault.
I'm happy to do that. And again, thanks so much. So the real key, I know we've talked about some real specific areas here, but the real key to helping your patients get the right care at the right time, in the right place, for the right price, is bringing a dedicated nurse alongside them. Notice I said nurse or physician, not a lay person like some other models, but having someone who's clinically and financially trained to navigate both the healthcare delivery system and the health plan system, handhold those individuals right from that initial point of sickness all the way through their recovery. And that's what we specialize in by providing patient-centric comprehensive care management.
That's great. And actually, we have one more question. By the way, if we don't get to your questions, we will answer them in writing when we send out the slides. What % of cancer patients are presented at a tumor board?
Oh, not enough. If I had to guess, I would say it's probably in the 30% range, unless you're going to a facility that is pretty world renowned for cancer treatment. But yeah, it does not happen often enough for sure.
Okay, and then let's just wrap up with your little statement. And actually, we don't want to forget this one, which is actually this is what our guarantee is based on. Is what is your per member per year or your per member per year expenses compared to averages?
Yep, so as certified by the Validation Institute, you can see how we perform here. Our average client is at about $9,142 per employee per year. So almost half of the national average according to the Milliman Medical Index. Of course, we have patient groups that perform much better. We have some that perform less well than those. Those, by the way, I'll tell you a dirty little secret, Al. A lot of those that are in the loosely managed or worst performing groups are hospitals and healthcare providers who are paying themselves for their own care, so they want to perform at that level. So you can do a lot in terms of PEPY. What it really boils down to is if you get the right patient into the right care at the right time, at the right place, right price becomes the natural consequence. So it ends up being a thing of beauty.
Great, thank you. And let's get into, I also forgot this one, which is, this is actual data from a named place. This isn't like, look, it's client A kind of thing. Take it away.
So this is Peoria Public Schools, and they've been with us since January of 2014. And you can see prior to that where they were performing right on par with Milliman Medical Index rates, we were able to lower their costs and keep them fairly stable. So we've still not gotten as high as they were when they started with us. And I know you're probably wondering, right, the Milliman Medical Index has only gone up 20%. I think that's an extraordinarily conservative trend line. And still we blow it out of the water. So we're really happy about this, and we do this with groups all over the country of all different sizes, all different sectors and industries. So pretty typical performance for AIM services.
Great, and just to keep us on schedule, I will just jump to what our guarantee is here. Your price, you have a typical price listed there that I assume is going to vary by the size of the account. And for that, you're getting reductions that are large multiples of that. You may be able to achieve something close to a 50% reduction versus an index. What Quizzify specifically will guarantee for you folks, this is us guaranteeing for you, in addition to anything else you guarantee, is a 10% reduction in inpatient days in the first full year. Now, obviously, 2020 is going to mess things up, but I'm sure that Milliman will figure out a way to adjust for it. So this will be a 10% reduction in adjusted inpatient days. Okay,
Thanks for your
shockingly,
vote of confidence.
well, thank you for giving me the opportunity to make the vote of confidence. Shockingly, we are right on time. So with that, we will go to the introduction to the next speaker, which is, hang on, we have a question coming in. Love what I have seen. Is there a way to get the slide? We love questions like that. Yes, all the slides will be sent. Okay, the next person I would like to introduce is Bill Miller. His bio speaks for itself. Ernst & Young Entrepreneur of the Year, CEO of Drexi since 2019, has many talents, one of which is apparently not cutting and pasting his picture into his bio. Now, he will claim it's us. That's his story, and he's sticking to it. But this is the guy. And I'm going to start by telling the story of how I met Bill. Just like my story of Deb, it's got some color in it. Next slide. Okay, so I live on generic Ambiens, okay, my Zolpidem. I take them every night. I'm addicted. I will admit it. I not only chew them, but I like the way they taste. Now, in my defense, I only do it 5 milligrams. And what happened was, I don't know if it's the health planner, the employer, the consultant, or somebody, last year they said, I can't get the 5 milligrams anymore. They're not covered. It has to be 10 milligrams. This is really smart policy. Let's insist on people taking more of an addictive drug. So I don't want the 10s. I already cut them in half sometimes. So I get the 5s. They're not covered. And I go to CVS. This is the first time hearing that they're not covered. And I get this bill for $136 that you can see. And when I complained about it, CVS said, well, Optum negotiated a discount of $30. So there's your discount right there. I'm saying, hello? So I'm thinking, I pay them and I think, oh, geez, it's going to be awful. And then I happened to attend a board meeting of a large provider organization where I'm on the board. We've got clinics all over the place, including the one I go to, that has its own dispensary. And they're talking about this, and they say, well, our dispensaries lose money when we sell the drugs. And somebody on the board says, why is that? They say, because we sell them so cheap, we can't sell them for what CVS sells them for. So I think light bulb goes off. Next time I get my Ambiens, I'm going to go to the dispensary. And sure enough, I go to the dispensary, and that's the bill right there, $18.40 for the exact same thing, 85% less than what it costs at CVS. So then I meet this guy, Bill Miller, and he tells me what Drexi does. And I say, sorry, Bill, there's no way you can do better than this, because not only did I just get an 85% discount, but I happen to know that these folks lose money on this thing. So Bill says, well, what's the drug? What's the dosage? Yada, yada, yada. And next thing you know, I'm in Walgreens and I am paying $3.25 for the exact same 95 milligram tablets that I was paying. Thought I was getting a great deal for $18.40. Imagine my surprise. I'm thinking, I got to get to know this guy, and that's why we invited him here. And now let's move to the first question. Okay, apparently it's not just generic Ambien where the price varies all over the place. So there's something called the average wholesale price, at which typically you're paying 80% less than that. So the question is, what is the average wholesale price range for generic Lipitor? Got to slip my glasses back on here. From just one source. So this is just one source, Metaspan. Remember, this is the exact same strength, exact same dosage. What is the range? Is it 11 to 25, 26 to 55, 56 to 225, or is it 11 to 225? Now, while the panelists while the attendees are voting, we have a whole bunch of questions coming in, and I'm kind of a little bit overwhelmed by them. Hello. We got something from, Deb just sent a text to everybody, so I don't have to say what it is. So the question that we have that just came is, what is the difference between a Drexi card and a PBM card? They're both cards, you show them both. Tell us about it.
So Drexi, there's a Drexi card because we wanted to give anybody the ability to go get pass-through pricing out. Just like you can sign up for $7 and go and get what is Drexi's price at the drugstore. Nothing added in, no margin, no spread, and then a Drexi PBM card is where we actually contract with the employer to provide full service PBM management. So we manage the formulary and the pricing and what the copays are, and we work with the employer to make sure that those are optimized. So it's really kind of a direct to consumer. And when you go and look at Drexi prices and they're half the prices of good RX, you realize that that's the margin they built in.
Okay, well, with that in mind, and first of all, before we actually go to the poll, this was kind of a leading question, and yes, 70% of people did get it right. It is 11 to 25%. I'm sorry, 11 to $225. Before we get into that, there's just a few leftover questions. We're not going to get to all the questions, but yes, the Peoria data is longitudinal. And there are studies about the percent of cancer diagnosis misdiagnosed. We have in Quizzify, and I'm sure Deb has them as well, and we will sell them. And I'm going to actually stop answering the questions live for now because there are just too many of them, which is great. You know, we got a ton of people on this call. So with that in mind, let's go to the next slide. Okay, so we've just learned that there's a big range of difference in average wholesale price, and typically you're paying as the employer, you're contracting for AWP minus 80%. So the question is, if the contract is notarized, does it guarantee you a fixed price for AWP minus 80%? Is it A, yes, a contract locks in a price, that's why you have a contract. B, if it's notarized, the price is locked in. C, the AWP is fixed, the 80% discount is fixed, ergo, AWP minus 80% is fixed. Or no, there are at least 4 ways your fixed price can be increased by the PBM. So while we're doing that, I'm going to try to get to a couple of these questions, the chat box and everything else. How is it that the price can vary like this when the price is coming from the same source, Metaspan?
Well, you know, you have a Metaspan. So Metaspan gives the AWP for every manufacturer, and there are 39 different manufacturers of atorvastatin, calcium, and Metaspan, and so those prices range, and you know, you see what a dramatic swing it is, and with those, the PBM can shop what manufacturers they want to charge, and it creates such a pricing disparity that that nobody really knows what's going on. And that's where MAC lists come in, where a PBM can actually say the maximum allowable cost for a drug is X, and that's all we're going to pay a pharmacy. That's how you're protected as an employer from these wide-ranging prices from manufacturers. However, PBMs can use them to their advantage as well, which is dangerous.
And speaking of dangerous, that takes us to the answer to the answer to the polling question, which is, yes. Okay, yeah, you guys have kind of figured out that the answer is always the most shocking thing here. All right, so Bill, perhaps you could, it says there are at least 4 ways that you can do this. And, you know, we all want to get on with the rest of our lives tonight. So maybe you can just do 4 of the ways, and anybody who wants to contact you can learn about more.
Yeah, absolutely. And, you know, it's such a game, and everybody knows, you know, I think the audience of this particular webinar understands what the acronym really is, and then what the industry ain't what's paid, what it stands for. And I think that kind of stands out with, well, hey, if that isn't it, then how in the world can any prices be based on it? But, you know, we talked about the data source, and the data source, and Metaspan has 39 different manufacturers, and then there's another data source called First Data Bank, and then Elsevier. And PBMs, traditional PBMs, will actually come up with their own AWP list. And in their contracts say, we can choose our AWP list however we want. So they can adjust the AWP any way they want. So if they want the price of a drug to go up, they've guaranteed 80% off, they just raise the list price. They can bill off of multiple maximum allowable cost lists. They can pay the pharmacy off one, and then they can charge the employer another, which creates a spread pricing. They have, they can do manufacturer shopping. They can say on their list that they're going to pay a pharmacy the price of a low cost AWP, and they're going to charge the employer off the manufacturer's AWP of a high cost. And then there's drug classifications, which is an entirely complex system of how a PBM says what is a generic, what is a brand, what is a specialty, what is multi-source or single source. And those definitions, while they're supplied in the industry somewhere, who knows? Who knows what a PBM classifies it, because they can really choose.
Well, and I'd like to add a couple things to that. One is that this whole AWP thing actually predates generics. And when in fact there was one manufacturer of one brand name drug, it made a little bit of sense. But it's exactly the opposite when you have generics. There's no concept of having a fixed AWP. And the other thing I'd add is that one of the ways they game the system, and this is arithmetic, is if you have and Bill, you mentioned they can classify things as generic or brand name. They've got a little bit of flexibility there. If you have an expensive generic and you move it over to the brand category, that makes the price, the apparent cost of the other generics go down, and it makes the apparent price of the brand names go down.
Yeah, it's called discount shopping. So a PBM will give you guarantees. As soon as somebody gives a guarantee, they have to build in hedge and margin to meet it. But they put in these discount guarantees. Well, if they move the products around between the different classifications until they meet their numbers, then it's kind of a shell game.
Well, for an industry that doesn't actually produce anything, they seem to make a lot of money. In the immortal words of the great philosopher Sammy Davis Jr., nice work if you can get it, right? So let's go to the next slide. Okay, we have another polling question, which is, why could the rebate on a brand name drug cause a generic to be excluded from covered drugs? Is it A, the PBM can keep most of the rebate as profit and exclude the generic to drive volume to the brand name? B, obviously this won't happen. The PBM must pass through the entire rebate and the generic could end up costing more. Or C, the PBM shares the rebate with the employer so that the cost of the brand name becomes lower than the cost of the generic, even though the list price is higher. So while we're doing that, let's see if any other questions came in here. We have some coming in on the Q&A. Bill, have you had any luck carving out carrier PBMs in the Northeast among fully insured health plans?
We have it depends on the contract that the carrier has. Most of the time, though, it takes a courageous employer to say, we're going with an independent TPA. That way we can carve out things like medical management. You want Ault in there, and you want Drexi in there, and you want people who believe in these free market principles, and they can drive the cost down through transparency. Carving out just the PBM, while it does save great money and can be done sometimes, what happens is the carriers say, well, we've given you this administration credit, and rather than give you $35 cutting you a check to letting us take your money on the back end on the pharmacy, they say, well, we're going to have to charge you an additional amount for carving out the PBM because it's difficult for us to connect with them. But connecting with them is really, we've done it in a day and a half. It's not a difficult process, but they throw that up as a roadblock. But we can, we'll certainly work with anybody and make sure that we can get connected with any carrier or TPA that needs to be connected with.
So we got a great question to lead into the next section. Oh, we got to do the poll. So let's do the polling result. A PBM can keep most. Okay, you guys are on to our little games here. Okay, that is correct. This actually not only leads us to the next slide, but also we got a question: are we ever going to see reasonably priced insulin again? And I do believe your next slide talks about insulin.
Yeah, so the answer is yes. We already see affordable insulin, and $132 for insulin is the list price. And I can tell you that we've seen in Drexi's network prices on insulin as low as $40. And what's happened in insulin is over the last 6 months or a year, the government went back to the manufacturers, Eli Lilly and Novo Nordisk, and said, you've got to come up with some sort of a solution. So both of the manufacturers started doing this. I'm just going to use Eli Lilly as the example, but there's certainly parallels with Novo Nordisk. Humalog is this expensive insulin. It's $275, and it's on every formulary that focuses on Eli Lilly because there's huge rebates for the PBM. And Eli Lilly manufactures Insulin Lispro. It's manufactured in the same plants. It's manufactured by Eli Lilly. You can go to LillyInsulinLispro.com, I think is the website. It's an Eli Lilly website that actually explains that it's the same drug, and it has a big asterisk in the middle that says you could pay less money if you're fully insured getting the brand name. And this is the reason why. The PBMs will put the Humalog on the formulary as a preferred brand name, and they will reclassify this insulin Lispro, which is a generic made by Lilly, onto a non-preferred brand. And it changes the copay structure. So when a patient goes in and talks to the pharmacist, says, I'm here for my insulin, the pharmacist runs the claim and says, hey, it's $50 for the Humalog or it's $100 for the generic. Which one do you want? Well, naturally, the patient says, I'll go for the $50 out of my pocket. And the PBM ends up making a $100 rebate, and the plan ends up paying $220 for this insulin, which we've seen all the way down to $40 or $50. And because of that steering, the generic is all but eliminated. There are even PBMs, Optum and ESI in particular, who will not allow the generic on their formulary. They force their patients to go to the brand. They claim it's because of some manufacturing processes or quality, but this is a drug manufactured in Eli Lilly's plant by Eli Lilly. So it's crazy that these sorts of games happen, and insulin is criminal right now. Insist on insulin Lispro or insulin Aspart. Those generic versions will save hundreds of dollars for the members.
Thanks for, yes, and let's go to the next slide. And the one thing that that I would observe is that the thicker your contract with the PBM, the more you are paying net. All right, so let's wrap up this, and then we'll get into what our guarantee is. And that, by the way, is the answer to a question that came in, which is these things seem very opaque. Yes, the longer the contract, the more opaque they are. That is true. Speaking of opaque, why don't you wrap up with what it means not to be opaque?
Yeah, the job of these PBMs are to hide things, and they have about 30 different buckets of money, and when they say they give 100% of the rebates back, they give 100% of the rebates that they define as rebates back. They don't give back the marketing money or rebate administration money or mail outreach campaigns or any one of, some people say 67, but it's really infinite different ways the PBMs can take money from you. And the key really is a PBM without conflicts. That's Drexi. We align our financial incentives with the plan, so we don't make more money by increasing the number of scripts. We don't make more money by sending prescriptions into our own pharmacy. I think it's a huge conflict of interest where a PBM says, hey, I know I can get a prescription for $4,000, but I'm going to send it into my own pharmacy and it's $5,000. They make those decisions and they're not in the best interests of the plan. So without conflicts, Drexi can choose the best place to acquire a prescription for the lowest cost. We can use alternative sourcing with international and foundations. If a group has access to 340B, we can help direct into there. Collaborative formulary management so that we don't get into these problems where Lispro is excluded. We work with the advisor and the employer to come up with the best formulary for lowest cost. And we cooperate with any third-party cost containment solutions. I've been on the phone with Nurse Deb saying, hey, we have this particular prescription and it's prior authorization. Let's get them into medical management so that we can work together to make sure that that's the right prescription. That's the right therapeutic treatment for this particular patient so that we save money in the long run choosing the best option. Drexi's, we talk about the Drexi card that's available. Anybody can sign up at Drexi.com, $7 per member per month. There's a family option and just get the best prices. And crazy enough, on my rosuvastatin, I can pay cash with Drexi and save $34 off what my copay is with my Blue Cross Blue Shield card. It's criminal. For employer groups, we charge between $4 and $5 per member per month, and we'll take files from any advisors and do free analytic and free claim analysis to show what we can save on there. And generally, we're looking at about a 30% to 35% savings over a traditional PBM like Optum or Express Scripts or CVS, and we save 50% on generic drugs over many of the pass-through PBMs. So.
Well, let's wrap because we want to stay on time. We do have a ton of questions coming in. I'm not sure we're going to be able to get to them, but just to wrap with the guarantee, I actually thought your average was 22%, so I might be wrong on that. But we will, Quizzify will put our own money up for that you will get 10%, and that's just a start. Obviously, what we guarantee, we don't want to lose a third of our fees. So what we guarantee is going to be a fraction of what you can save. So let's move on to the Quizzify section. Ah, my favorite. Okay, so we're going to start with something that some people still do in lieu of Quizzify, which is they screen their employees. And the question is, how often should healthy employees under age 35 be screened for diabetes and cholesterol? Is it every year, every 2 years, every 3 years, or not at all? And while we're waiting for that, let me see if I can get some of these, at least one of these questions going.
Al, I would say don't forget, when you use AIM and Drexi in combination, it's a great solution to combat buying and billing drugs through the major medical, which is the loophole that providers try to put things through to keep them out of the PBM world. So there's a good synergy between the two organizations as well.
Okay, well, what can I tell you? It's peanut butter and chocolate, and we're the wrapping, you know. Actually, I'm good. We're gonna have to get to the questions at the end, or else answer them, because let's go with what the answer is on this one, Mark. What's the not at all is a very, very, very good answer, and in fact, frankly, is my favorite answer. But we want to be very conservative here, and very conservatively speaking, every 3 years for screening healthy employees is plenty. This is the Cleveland Clinic, and they say every 5 years for people who don't have, you know, significant risk. And the reason this is significant is they actually are a vendor of wellness screening. So for them to say you don't need to be screened every year, you probably don't need to be screened every year. Now, way at the bottom, it talks about diabetes screening. And once again, if you don't already have prediabetes or diabetes, every 3 years is perfectly fine, more than enough. So let's just, I mean, this is a fairly easy one, so we're not even going to ask a polling question about it. Let's just compare traditional wellness to Quizzify and figure out which is more efficient. In traditional wellness, they say, and this is direct quote from it's either Optum's or Cerner's health risk assessment, eat less added sugar. Well, thank you. Tell me something I didn't already know, right? And they line people up for these screenings every year. Now, you might say, why do they do it every year instead of according to clinical guidelines? Well, the answer is the vendor makes a lot more money off you if they do it every year. And health risk assessments. Have you ever had a health risk assessment where you've asked people whether they smoke or whether they drink, and then compare the answers you get to the actual answers, which is these days about 15 to 16% smoking, about 70% drinking? You will find that 2/3 of people are lying. And Quizzify will even guarantee that. Now, if you compare that to Quizzify, well, we're looking at, as you saw, going after these unnecessary, potentially harmful procedures simply by letting employees figure out for themselves that, gosh, it may not be a good idea to keep getting CAT scans all the time. We don't tell people eat less sugar. We take people who already want to watch their sugar, which is many of them, and we help them find the hidden sugars. And the sugars are hidden all over the place. If it's a processed food, and it is shelf stable, and it is not salty, it's got sugar. And medication safety. How many people here, I can tell you actually statistically that about 40 people here, maybe 50, are taking heartburn pills every night. Bad idea. About 50 people are taking those ZZZ Quill or Advil PM type drugs every night. Bad idea. These are not indicated for long-term use. And saving money in their own health care as well. Next slide. Okay, so let's, okay, we know what the answer is going to be. I think we can probably just get right. The answer is true or false. MRIs almost always decrease the rate of inappropriate diagnosis. Okay, so you folks are all onto our little games here. So yes, of course, the answer is false. And I think yes, these 9%, you guys have to come talk to us. They actually did a study, some folks actually did a study where they took a patient with a known diagnosis in her back, and they sent her to 10 different imaging centers. In those 10 imaging centers, they received 49 different diagnoses. No two imaging centers gave the same diagnosis, and only about 70% of them, only about 7 of them actually got, among the many, many diagnoses that they gave, the right one in there somewhere. So Understanding the limitations, we can go to the next slide. Understanding the limitations of scans is very important for employees because here's a news flash. You're spending a lot of money on these things, okay? This is a company that has a $100 million health spend, and we like using it because it's very easy to figure out percentages if someone's spending $100 million. $6 million of those dollars are going to scans. And if you look at the pie chart down at the in the lower right, you can see that the large majority of scanned dollars is going to MRIs and CAT scans. Next slide. So let's peel that out a little bit more. The CAT scans were a little bit more than 2 million. The MRIs were a little bit more than 1 million. Combined, they were 3.269 million. And they weren't paying much money. Actually, 769, when you, as Deb pointed out, a lot of these things take place in the hospital. 769 is not a bad number. What is a shocking number, and yet is still only about average, is if you look at total number of CT and MRI scans, 310 for every 1,000, actually I think it's belly buttons, not employees, for every 1,000 covered people, 310 scans a year. That's mind-blowing. All you have to do is just let people know that CAT scans are full of radiation, that MRIs might be wrong, CAT scans and MRIs might be wrong. MRIs have their own set of hazards too. And if you can just get a tiny reduction in those statistics, even if you're not paying that much per scan, you more than pay for Quizzify, which in this case would cost somewhat less than $98,000 for the year. Next slide. Okay, so surprise medical bills. What are the odds of getting at least one surprise bill in an in-network, so not out-of-network, in-network emergency visit or emergency admission? Is it 10%, 20%, 30%, or 40%? And once again, I think this is one where everyone's going to go with the right answer here. So we'll just jump to the polling answer and get into the cool. Yes, 40%. I mean, this is shocking. And yet, how many of you folks are doing anything about it? How many of you folks know that you can actually, and there is a link on this, it's actually 43%, and that's at in-network facilities. Next slide. How many, I'm sorry, the next slide and the other, there we go, okay. So how many of you folks know that you can actually get a card free that you can give to your employees, either as a standalone card, and by the way, those of you who can see me online here, as a standalone card that has our information on the front in case somebody gives you a hard time when you go to the ER, or a little piece of tape that you can, oops, it was upside down, a little piece of tape that you can put right on your insurance card that prevents people from overcharging you. Okay, so this is, so it's all free. We give this stuff away, and you don't have to take our word for it. It's in the New York Times. You can just click on the New York Times article about this. What we've done is we've figured out a hack in the law. I'm not going to call it a loophole. It's a loophole. I figured out a way that if you go in and you don't sign what they put in front of you, but in fact you give them this card, that they will in fact either charge you 2 times Medicare, as the card says, or you will not have a meeting of the minds, and they won't be able to charge you until they decide, somebody at a very high level decides, you know something, we better only charge this person 2 times Medicare, because if we take them to court and they win, it's going to get all over the media that the judge said 2 times Medicare is a reasonable rate, which it is, and they don't want to essentially set a ceiling on their prices. So that's just a tiny fraction of what we cover in surprise bills. And when I do the surprise bill stuff, also, I do like to give credit where credit is due. Speaking of Reese Cups, so I like to credit 2 people, David Contorno and Marilyn Bartlett, who you may have heard of, who taught me all I know about reference-based pricing, and my good friend Marty McCary, who taught me all I know about battlefield consents and the law that says you do not have to sign the medical, financial consent in order to get treated. What I did was I put that battlefield consent, the peanut butter, together with the reference-based pricing to create this card. So I didn't invent peanut butter, I didn't invent chocolate, but I did invent the Reese cup. Next slide. So I'm going to just turn this over to Mark now, and he will summarize.
Thanks, Al. I'm just going to make a couple comments here. We're really seeing that you know, health literacy education can create some really great healthy behavior change, and the additional byproduct is reducing medical waste, which everyone agrees is about 30% of overall spend. And in the example that Al and Nurse Deb were talking about in terms of the imaging, most large self-insured employers are spending between 6 to 9% on imaging. And by empowering your employees to ask more questions, because they know these tests can be unnecessary and harmful, this alone can be enough to pay for Quizzify. In addition to that, we'll educate about other procedures like spinal fusions, which only have a long-term success rate of 35%. And we'll obviously present that fact, but also present the alternatives like physical therapy and acupuncture, which we all know many patients don't go and do first before going into surgery. And this third point relates to what Al was just talking about. And just consider for a moment how valuable preventing just one employee from getting a $5,000 to $15,000 bill after visiting the ER. That's a surprise at pretty much the wrong time and something they might not be able to afford, and that can be eliminated through education. Now, here are just a couple other parts of Quizzify that are important to convey. We have a great content partner with Harvard Health Publishing. Doctors at Harvard Medical Schools review our medical content, and we can put this stamp on our questions. So when we're presenting something that's a little new and surprising, it gives people a little bit of extra confidence in believing it. At this point, we have 1,600 unique questions that are updated in real time. We were the first vendor to be out there with COVID-19 content. We're the only vendor to solve this ER surprise bill problem, again, through health literacy education. We were out with an immediate response when Zantac was recalled to talk about these other heartburn medications that on a long-term basis really have significant risks. And then in 2017, we were one of the first vendors to be out there talking about the risks of prescription opioids and the dangers when there were still a lot of entities out there promoting pain management. One of the other features of Quizzify that's significant is that we're digitally delivered, and that enables us to reach employees basically anywhere, which is important in this day and age. And what Quizzify will do is we'll offer an engagement guarantee, and then we'll guarantee that Quizzify will be the most cost-effective benefit as measured by the official Validation Institute tool. And there's a link here in the slide that you can go to and read about how that measurement tool works. And just one final thing about the cost of Quizzify. If you talk about a company that's 1,000 to 10,000 employees, traditional wellness programs will cost in the neighborhood of $75 per employee per year to maybe $150. Biometrics alone can be $40 to $60 per employee per year. Quizzify costs $8 to $12 per employee per year. In addition to that, we'll put an ROI and an engagement guarantee on top of that. So we're a less expensive wellness option. Now I'm going to turn it back to Al to sort of wrap with some more Quizzify-style questions.
Okay, before we do, we actually have a whole bunch of, I'm just sorry we're not going to be able to answer these all live. Is the number of surprise bills counting bills that patients get before their deductible is paid? The answer is yes, but actually for you as an employer, the worst surprise bills are the ones that they get after they meet their deductible, because they're not going to complain to you about them. You will just pay them. The card does work with the uninsured population as well. I mean, if you're not insured, you could be hit with 10 or 20 times Medicare pretty easily, and this limits you to 2. Would it prevent the hospital from providing financial assistance? Their financial assistance wouldn't put a dent in what they would normally charge. So you're much better off paying the 2 times. And then would it work with the bills from the emergency physician, the radiologist? Absolutely. So you could have an in-network emergency room and have out-of-network, I mean, the private equity companies have all bought these practices and consolidated them, and they stay out of network. The ologists, that's precisely where it does work. So now let's wrap with a question where we don't actually know the answer in advance. which is regarding the educational material that we presented here today. We talked about scans, we talked about drugs, inpatient cancer misdiagnosis, and cost versus quality. Did you learn something today that will affect your own personal or professional behavior? And now this one, I have to say, I'm just a little bit nervous because unlike the others, there is no correct answer. So we'll do a little Jeopardy music. Do, 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 do. And then, Mark, what do we have for the answer? Yes, score! And I expect you will all be signing up. Hey, by the way, on that thing that Mark showed about the Validation Institute and the being the guaranteed to be the best benefit, I think if you have Drexi and or AIM, we might be in for some competition there. So we welcome that competition. Thanks very much for the vote. And now we will close up by summarizing the guarantees, which are the reduction in drug spending of at least 10%, and you should get more. Reduction, actually, the one that we're guaranteeing is the inpatient days, because it's the easiest to measure, of at least 10%, and you should get more. And reduction in wasted or potential harmful medical spending that we will guarantee the other 67% of our fees for. And on that note, actually, we have time for 3 minutes of questions. Incredibly, most people are still actually on this thing. So let's scroll down the question list. Al, brilliant, entertaining, humorous, and informative. Thank you. Okay, well, that's not a question, but I'll take it. I assume we will get the reference material along with the presentation. Yes, all the links will work. And then for some reason, I managed to cut myself off from the earlier question. So there are a whole bunch that I think when I hit, oh, maybe if I hit answered, maybe I go to the answered ones. Yeah. Oh, Peoria is Illinois, not Arizona. How is how is Drexi different from GoodRx or similar programs, Bill?
Yeah, so GoodRx is not a PBM. They're an advertising agency. they actually advertise discounts and they say we're really cheap, but they have a spread in there and they use PBMs. Last count I heard was 9 of them, and those 9 PBMs run the transactions for GoodRx, and they pick the least one and then they put a spread pricing on it and mark it up.
Well, they still get a pretty good price, in all fairness to GoodRx.
They do, and they've certainly brought the discussion out into the forefront. You see their advertising everywhere. Yeah, so they've certainly brought the problem to the forefront of America's visibility.
I did actually look into GoodRx, and it was not anywhere near as good as your price, but it was $10 or something like that for the Ambience. Nice kudos to Ault for maintaining a below market cost for 12 years is a job well done. Bill, how can Drexi work in rural markets where there may be an independent pharmacy and a Walmart?
So we have 65,000 pharmacies around the country, and we have more pharmacies in our network than there are fast food outlets. So I mean, there's always a pharmacy you can go to. And if a pharmacy, we actually handle out of network pharmacies by when they run a transaction, it comes to us and we offer them our in-network pricing. Say, hey, if you want to fill the prescription and you want to be paid by us, we'll give you our in-network pricing, and we just suck them in that way.
Okay, and then the final one, because we're about to turn into a pumpkin here, whenever I appreciate that most people stayed on. How does Quizzify guarantee outcomes with AIM and Drexi? Do we access them through you or what? No, you can access them separately. All we need to do is be side by side. And it's a little one-page summary, and we have the link to the guarantee summary is right in this presentation that you will all be getting copies of. And thank you so much for being with us and for sticking with us the whole time. Bill, Deb, not just thanks for being on the presentations. I know it wasn't exactly a heavy lift for you, but thank you for being yourselves. Thank you for giving people these alternatives.
Thank you, Nurse Deb. Thank you, Al. Thanks Mark.
Guys.
And
love
all
the friendship.
Thanks for coming.
Mark, thanks for serving the MC role and wrapping up, and we'll talk to everybody soon.